Good morning, everyone. My name is Shannon, Clarke, and I also completed my practicum with the Capital Regional District in Victoria. So my interests are in health and the built environment, so I wanted a practicum that merged the fields of planning and public health. The CRD provided the perfect opportunity to merge these two fields, and I was lucky enough to work with the Regional Planning Department. Regional planning is responsible for a lot of different strategies in the region, but the largest one right now is the Regional Sustainability Strategy, which is a 25-year plan for the region. This plan covers a broad range of topic areas, from economic development to affordable housing, community health and well-being, to name a few. So my project involved developing a health equity evaluation framework to evaluate the policies in the RSS to ensure that they're fair and benefit diverse populations. I just want to define the term equity for those of you who may not be as familiar as us MPH students. So equity differs from equality in a very important way, yet the two terms often get used interchangeably. Equality simply means that the conditions are the same. So looking at the boxes on the left, equity in comparison means fairness. So when you look at the boxes on the right, we've elevated the person who's the shortest so that he can see the game as well. So inequities are differences that are systemic, they're avoidable, and they're unfair. Social determinants of health, such as income, education, housing, transportation, and opportunities for social engagement are not evenly distributed across all population groups, and this results in serious health inequities. People who are marginalized by their ethnicity, their gender, their income, their age, or their geographic location can be more susceptible to illness or disease for numerous reasons. They're more likely to live in poor quality housing, have high-risk work environments, have higher stress levels, experience food insecurity, and social exclusion. Unfortunately, there's also serious implications for society overall. So inequitable societies have higher crime rates, they have lower levels of trust, less social and civic participation, and therefore less voter turnout. They have increased debt and inflation, and they have economic instability. So basically, equitable societies are healthier, more sustainable societies. So it makes absolute sense that an equity lens be applied to a regional sustainability strategy. To make a case for the use of equity lens in the CRD, I needed to highlight equity issues specifically in the capital region. To do this, I researched equity lens strategies in other jurisdictions. I had meetings with CRD managers and staff, and I met with experts in the field to get their perspectives on how an equity lens could be applied in a regional government context. I then analyzed population demographics from census data and had the Regional Planning Department create maps for me that could illustrate where disadvantaged groups are living in the population or in the region, and therefore where we need to target our limited resources to improve access to services and amenities. This map, oh shoot, this is terrible. This is not how it's supposed to look. This map shows low educational attainment layered with public transit routes. Can't you tell? So for our purposes, low education is defined as those who lack any diploma, certificate, or degree. So the highest proportions in the population are shown in red and orange, which you can't see, and the green are areas that have less so in the population. The purple lines, which luckily are still purple, show the public transit routes, and the little white dots on top of those routes show the bus stops. So we can see which neighborhoods have a high proportion of people with lower education and how accessible public transit is to them. This is a map of low-income children and youth layered with cycling infrastructure. And again, it's really hard to tell up on the slide there, but the colored lines show the different types of infrastructure. So a bike lane versus a bike trail. So shared roadway versus the Galloping Goose or something in Victoria. These maps allow us to pinpoint areas that may be in need of better access to active transportation modes. Providing affordable transportation is just one way to mitigate the negative effects of inequities. It lowers the cost of living, it provides opportunities for social engagement, and it increases physical activity levels. Overall, my report to the CRD highlighted the need to identify disadvantaged groups in the region and then to use universal strategies, but ones that target groups proportionate to the level of disadvantage. We do that by looking at where disadvantaged groups are living in the region and then targeting our limited resources to improvements in those specific areas first. So this chart shows us how to apply a universal approach, so across the social gradient, in this case income, and then targeting our resources to improvements for the lowest groups on the gradient. Sorry. So this is my deliverable. After highlighting all the inequities in the region, I needed to create an evaluation matrix for the sustainability strategy itself. So I developed this table using a combination of several different equity lens approaches and equity impact assessments. In a nutshell, the matrix requires the evaluator to consider how a policy across any sector will impact diverse population groups. So if a policy might inadvertently increase inequities by mostly benefiting those with a higher social position, then it gets a score of -1. If a policy benefits all people, regardless of their level of disadvantage, then it gets a score of 0. It's neutral. And if a policy reduces inequities by helping primarily those who are disadvantaged, it gets a score of 1. So these scores can then be totaled to see which policies are doing the best and which ones may need some improvising to ensure that we aren't inadvertently increasing inequities. As with any project, mine definitely had its challenges. The first challenge was finding examples of health equity evaluation frameworks at a regional government level. There's a lot of work being done on equity, but most of it's being done at a local government level or utilizes health equity impact assessment, which is a very in-depth, time-consuming, multi-step, multi-team process. A second challenge was a slight lack of enthusiasm about the concept of equity from some of the higher-ups in the organization. They either felt that an equitable society would not be beneficial to the economy, that an equity lens would be too hard to apply across all regional policies due to limited time and resources, or that it was not applicable to such high-level policies and was not within the CRD mandate. Though it's definitely disheartening to get this feedback, it gave me a lot better direction for my rationale. I knew the points that I needed to hit to make sure that health equity was relevant to the CRD. And lastly, I found it difficult to develop the evaluation matrix itself. So I thought it was a bit of an oversimplification of equity, which is a very complex issue. So providing a scoring system and assigning a number was, to me, oversimplifying the issue a little bit. However, having said that, I do think it's a really important first step, and it does help to put health equity on the policy radar at a regional government level. Overall, this was a phenomenal practicum experience, and I learned a lot and felt very supported in my project by everyone around me. The practicum allowed me to apply all of our coursework into practice, and I was able to have amazing discussions about health equity with a diverse range of people and stressed the need for greater intersectoral collaboration. So Victoria may be a bit of a loss leader when it comes to health equity, but the word is slowly spreading. And eventually, we will create a healthy and sustainable society that benefits all people. So I'd like to quickly thank a few people who helped me get to where I am today. Jeff Waitman, my practicum supervisor. Victoria Barr, my UVic supervisor. Ardith Evans, my CRD partner in crime. Dr. Catherine Worthington, my first reader, and Dr. Michael Hayes, my second reader. Thank you, everybody, for making this such an amazing experience.
Thank you, Shannon. And before I come to questions, can I just ask that we have our intrepid BA presenters come up to the front and just cluster, because we just have one more MPH before it's your turn. So can we have Caitlin, Danielle, and Devin down in the front rows here, please? Thank you. And while you guys get yourselves settled, I'm going to take it up for questions.
Hi, that was great. I'm really interested in how you found or chose an appropriate health equity approach or tool, or did you? How did that work for you? Because you made an equity framework. Mm-hmm. What was your foundational tool? Because you're right, there's a lot of really big, broad ones.
Yes, it was definitely a combination of numerous different equity lens tools and equity impact assessments. I reviewed a lot of different ones, and there was really nothing that fit with the regional sustainability strategy. It's an enormous plan, and it covers such a broad policy area. So I needed something that could fit nicely into a table, because the CRD needed something that they could use to evaluate policies relatively easily. Yeah, it's a tough question, because it definitely took a long time to figure out how I could be combining. I pretty much just invented one. Yeah, it is not anything specific.
So my question follows that nicely, and that is, do you have permission to share?
To share the evaluation framework? Oh, I'm sure I can. Yeah, the only thing that was confidential was the policies themselves, because the sustainability strategy is still in its draft stages. But the framework, I'm sure that's not a problem.
I'll send you a note.
Great.
Thank you. There we go. We got some KT going on right here.
Thank you.